Thank you so much, ma'am, for the welcome. And before starting with my topic, I would like to thank Dr. Shah, ma'am, for inviting me here. It is my first meeting for all of you, and I hope to have more and more sessions so that we all be together in the journey of genetics, because genetics is something which nowadays is present in all the fields, and we don't have to forget that the patients that you handle are the ones which comes with a very limited phenotype and clinical features, that is the fetus. And as I always say, that fetus is none other than but a patient with a very limited clinical features. So to deal with them and to take a correct decision, we have to move with the pace. So today my talk will be, I will be covering the conventional part, that is the marker screening, which I'm sure everybody here is aware of, that is the dual marker, quadruple marker and triple marker, and then the advanced screening test, that is NIPS or NIPT, NIPD, that is non-invasive prenatal testing or screening or diagnosis. And followed by that, I would just like to introduce about the genetic testing, or especially we call it basically diagnostic testing. So when we say the diagnostic testing, so we know that if a marker is coming positive, so in that case, what we do is, at times it was like, okay, if it is positive for Down syndrome, okay, fine, terminate it. But then we have to keep in mind that it is just a screening tool and not a confirmatory test. So for confirmatory test, we have n number of tests when it comes to chromosomal abnormality, whether it is numerical, structural, or it is a single gene disorder. So I will be covering all of that. So before that, I would also like to thank Pathkind, because they have given me this opportunity to meet you all. So Pathkind is a venture of Mankind Pharma, which I guess everyone is well aware of, and they have started 6 years back as Pathkind, and they are currently they are presented in somewhere around 26 states, and more than 3,000 collection centers they have. And if I talk about Delhi NCR, they have 4 labs, and which they are a multitasking lab, which do from the basic testing, the biochemical testing, to the high-end genetic testing. So it is all under one roof. So now I will start with my presentation. So I know the topic looks bit lengthy and bit confusing. So it is just that it is an integrated approach for utilizing biomarkers, non-invasive prenatal screening and prenatal diagnostic for a comprehensive fetal. So now, as a geneticist, as a genetic counselor, as we all know, that the prenatal period is basically divided into 3s: first trimester, second trimester, and third trimester. So as a genetic counselor, my major interest is in first and second trimester, because that is the period where I can help the patient, I can help the clinician to interpret the results, and we can find out a conclusive result for that particular patient. So the first trimester and second trimester, that is again 0 to 12 weeks and 13 to 24 weeks. Now when we talk about prenatal testing, if I talk about 20 years back, babies were born back then also, no testing, nothing were performed then also, but then still babies were healthy. But then what is the data we have? We don't have any particular data. Most of them, even the parents also say कि नहीं, हमारा जो बड़ा बेटा है वो तो बिल्कुल ठीक है, उस टाइम पे हमने कोई टेस्ट नहीं करवाया था. But then now why do we need it? So they have this thing कि no, these are just the fancy tests which is not required. But here we should know that why do we need it. Firstly, it provides valuable information about the baby's health, and secondly, also it understands the risk and the benefits during that is happening in the prenatal period, and how we can provide a prenatal care, if at all, if there is any complication regarding to the prenatal screening. So now prenatal testing is divided into 2. One is prenatal screening, the other is prenatal diagnostic testing. So screening, I would just give an example. So when we go to the airport, I'm sure everybody goes to the airport. So there is a normal security check that happens. Then you get yourself tested, you get the entire luggage. But then how many times have you noticed it that out of that long queue, just one or two, they are just taking it separately for doing the detailed analysis that yes, we are suspecting something. So the security that we are providing, that every passenger is having, that is basically a screening test which is equally important for each and every pregnant mother or the one who has conceived recently. And it is, yes, it is affordable, easily available, it is available at the doorsteps. It's just, nowadays screening test, whether it is dual, quad or triple, it's just a phone call away. You just need to give a call and your sample is collected, and within 2 to 3 days the reports are out. Now coming to diagnostic test, when we are suspecting that yes, it could be something high risk, there is when we need to have a definitive answers, because because I believe the parent, the newly conceived couple believes in his obs and gynae more than any other doctor. I recently had a experience where the couple said, I was counseling, नहीं, the child was 5 years old, but then she still mentioned, मैं तो अपनी गायनी मैम से पूछ के ही बताऊंगी, because that 9 months she was there with you. So anything that comes up with that trust. So similarly, to provide those answers, the confirmatory answers, we have diagnostic tests. So now prenatal screening, prenatal testing is divided into 2, as I just mentioned. So prenatal screening is also divided into 3. One is the conventional maternal blood serum test, that is the dual marker or quadruple marker. The other one is the ultrasound, which plays a very, very important role. Still nobody, none of the tests can replace ultrasounds, because ultrasound holds a very important role, because we cannot dig our hand inside the stomach and we cannot find out what is the abnormality. It is just the ultrasound which helps us to know what is the exact situation of the fetus. Then comes the advanced test, that is the NIPT, that is non-invasive prenatal testing, which we will be discussing in detail. Then is the diagnostic testing, which is the confirmatory test. So in India, chronic villi sampling, that is CVS, and amniocentesis is the most commonest ones, and that this is done in first and second trimester. But yes, chordosynthesis is also done by a few of the fetal medicines if it is a third trimester. So now coming to the markers, the basic markers. So if I talk about purely the dual marker, so if I am just sending a sample of a dual marker which says it has 2 markers, that is free beta HCG and PAP-A, with if I am clubbing it with the maternal age, so that is maternal age plus free beta HCG and PAP-A, so these 2 markers and 1 maternal age. So the detection rate of that dual marker would be 60 to 65% only. Then now if I am combining the dual marker, maternal age, with NT and NB value, the detection rate hits up to 90 to 91%. Now more the soft markers, because here we know in dual marker we will be just having 2 biochemical markers. We cannot increase that in first trimester in initial stage. So what we can do is we can increase, for the better detection rate, we can increase the soft markers. So to get the detection rate up to 95%, the maternal age, 2 markers for dual marker, and then NT, NB, tricuspid flow, facial angles, and ductus venosus. These are the most commonest one if you want to have a better detection rate for dual marker. Now coming to triple and quadruple marker, as we all are well aware of that triple is now obsolete, and most of us are not using triple marker because the detection rate and the false positive rate is very, very high. So when I talk about the false positive and false negative, so that means if a report says that this baby is positive, that means what is the percentage that yes, this fetus is positive. So that is the false positive, and then comes the false negative, that you have given a negative report but then a baby is delivered with Down syndrome. So that means the dual marker or quadruple or triple, any marker comes up with that is having a false positive or false negative rate. So because of the detection rate, yes, the triple marker is obsolete. Then comes the quadruple marker. So quadruple marker holds a very special information with it, because it has one of the most important most important marker, that is alpha fetoprotein, which coincide with open neural defects, NTD, ONTDs जिसे हम बोलते हैं. So the detection rate is, yes, comparative to dual marker it is less, but then still, if I only talk about alpha fetoprotein, the detection rate is high, that is approximately 80%. And there is no diagnostic test. Even if a quadruple marker says that, because I get a lot of queries saying that ki alpha fetoprotein levels are increased. So now what to do? What is the confirmatory test? There is no confirmatory test as of now. The only confirmation is that level 2 में deep ultrasound, detailed ultrasound करवाना. There is no exome sequencing, no Sanger, no fancy test, no jargons in genetics are there, which can detect the 100% detection for alpha fetoprotein. So now, if you get a report of a dual marker, and if it says that it has increased SCG, that is free beta HCG, so it coincides with trisomy 21, and if it is decreased, it coincides with trisomy 18. Similarly, if it is reduced PAP-A, so that is again either it is trisomy 21 or trisomy 18. So now most of the reports come which has different parameters, which will calculate, which will give you a lot of graphs and a lot of interpretation, maternal age risk, then marker risk, that single marker risk, then okay, depending upon NT risk. So what exactly we have to look into? So there is when we have to look for the overall risk, and also individual marker risk is very important, because at time if a lady is 23 years old and according to the calculation by the maternal age, both the markers and NT, supposingly NT is slightly increased, that is 3 mm, not just a borderline increase. So in that case what happen is, if she is 23 years old and the report says that the risk is at low risk, but then you have to check that this is the low risk depending upon the maternal age, then the NT values, and also but then if you just check for the risk for trisomy 21, then you have to look for HCG, and if PAP-A is increased, then it is for both 21 and 18. So that is what we have to look into, how we interpret each and every particular data. So now coming to the first trimester screening, here I will just talk about the dual marker, not the quadruple marker. So if it is low risk, then half of the problem is solved. So many a time patient comes to me and says, when I ask him, for example, if there is a child who's having developmental delay or who is having developmental delay and difficulty in walking and XYZ, anything which is related to neurodevelopment, whenever they come and whenever I ask them, do you have any genetic testing done or what was the antenatal history, so they always say one thing, ma'am हमने ना dual marker करवाया था. So we were guided or we were counseled that बच्चे की बुद्धि का विकास, we check the development of the baby's brain in the dual marker, but we should always keep in mind that whether it is dual marker, quadruple marker, or it is NIPT, this will only rule out the trisomies, and higher detection is for Down syndrome, that is trisomy 21. So we cannot say that if any of the markers is at low risk, then there is a 100% guarantee that yes, your baby is normal, because there are n number of genetic conditions, n number of chromosomal abnormalities which is beyond these 3 trisomies. Now coming back, if it is a low risk, you can always tell the patient that yes, you are at low risk for these 3 trisomies. Other than that, we are not sure. It could be XYZ thing also. For that, you have to get a detailed ultrasound done. So the level 2 ultrasound should be counseled when you get a negative report of any of the markers at low risk. Now coming back to high risk. So high risk is again divided into two. One is 1 in 250, the other is 1 in 10. So I would just want to make this session a bit interactive one. So imagine a scenario where a couple is coming for a preconception, and this lady says that my first child is Down syndrome. And this is a free trisomy, that is trisomy 21. So no need for couple karyotyping also, because this is not Robertsonian or imbalanced translocation. So couple won't be a carrier. So it is just a pure Down syndrome. Now she wanted to conceive again. So now how would you proceed, and how would you tell her that okay, you can go with this, and what all are the screening tests that would be given or offered to that lady? NIPT. So reason why directly we are doing NIPT and not dual or quadruple? Now this was a high risk when a couple or when a mother is at high risk in 1 in 200 or 1 in 250. Now what if there is a strong family history and the risk is 1 in 10? There we will directly go for MNEO. There is no point in going for NIPT also, because again NIPT also has 0.1% chances, and again it is a screening tool. Now coming back to intermediate risk. So intermediate risk, sorry, it is 1 in 50 it is written, it should be 1 in 250. So intermediate risk is a very, basically it's a clown where we don't know what is the actual ratio, because none of the reports says that intermediate risk will be, it's 1 in 250, 1 in 300, 1 in 900, we are not sure about it. So to go about it, if the patient is good and good affordable, then directly go for NIPT, because that is more sensitive test. But if there is a challenge, because we have to keep in mind that we live in India where affordability is the biggest challenge, especially when we talk about genetic disorders, the bare minimum test starts with 10,000. So keeping that everything in mind, for such intermediate risk, you should always counsel the patient, if it is dual marker, let's go for quadruple marker. And also level 2 ultrasound plays a very important role. If there is just one biomarker, then the risk is okay, that it is low risk. If it is two or two biomarker present in any of the fetus, then ultimately, no matter what is the screening tests are saying in their reports, you ultimately have to go for the diagnostic testing, and why and how to know the answers. So now, so as we were discussing, quadruple marker, it has 80% chance or detection rate for open neural defect, 70 to 75% chance for Down syndrome, because it has a special dimeric inhibin A marker in it, which is basically 10% more sensitive for Downs rather than other trisomies. So now this was the sensitivity and specificity. So I'm sure you might be getting a lot of queries from different companies that, you know, we have this much sensitivity, we have that much specificity. So what exactly that means? So sensitivity is basically the percentage of affected pregnancies that are screened positive. So that means if it is actually screened positive, is it actually positive? Because all the labs, all the hospitals, those who are doing these tests, they are under PCP-NDT guidelines and they always collect the data. So PCP-NDT, that is when they are verified that yes, this lab can be said as FMF lab or a certified lab for this. So specificity and sensitivity is very important for you to know that what is the specificity and sensitivity of a test is. Now coming to the most hot topic, that is non-invasive prenatal screening. So I'm sure everybody here would know about what NIPT is. So NIPT is basically a high-end test, I would say. So basically NIPT is something which is a high-end test where we screen the fetal DNA. That is not through a invasive procedure but through a non-invasive procedure. So what happens is, in our textbooks we used to study that mother circulate the nutrition from the placenta. So similar nutrition, it is not unidirectional, it is bidirectional. So the baby sends the cell-free DNA which is floating in the embryo, goes back to the mother. So when it goes back, that basically gets spreaded all over the mother's blood. So what we do is we just collect the mother's sample, and you might have been, whenever you order NIPT, you might have heard of it that MCC contamination to nahi hai, ya what is the fraction of that DNA. So this is what, when we extract the DNA, the cell-free DNA of a fetus from mother, that is where we start doing the analysis. So there are certain facts about NIPT. First of all, it is also known as cell-free DNA, which we are all aware of. Secondly, it uses to it's circulating the cell-free DNA, and it is derived in the placenta. Now the most important question is, what is the right time to do NIPT? Multiple papers says after 8 to 9 weeks, some says after 10 weeks, some says 11 weeks. So ideally, as per papers, it says yes, after 10 weeks you can share the you can do the screening for this, but then after, it should be after 11 weeks, when we have proper ultrasound details, and more the gestational age, more the DNA. So that is why we give that buffer time. It is in papers, it is written 9 to 10 weeks, but it is always better, because whenever you send most of the time what happens, when you send a sample for at 8 weeks or 9 weeks or 10 weeks, multiple times you might have observed that the lab says there is inadequate cell-free DNA. So more the gestation age. So after 11 weeks, it's always advisable to go for NIPT. Secondly, more the gestational age, more would be the cell-free DNA. Now, what would be the adequate fraction of that cell-free DNA? Multiple labs comes and say that you can do it at 1%, we can do it at 2%, but as per the guidelines, as per the ACOG guidelines, it's 3%. Minimum 3%, and maximum it can go up to 8 to 10 and whatever percent it is available, but minimum 3% hona hi chahiye. So whenever you are getting an NIPT report, you always ask for the cell-free DNA concentration also. If it's mentioned, it's good. If it is not, for your better understanding, that would help. Then coming to whom should we offer? It should be offered regardless, it should be offered to all the females, those who are expecting, regardless of their age. Because this is not, recently in December 2020, there was a guidelines from ACOG and ACMG which says that all the pregnant women, regardless of their age, should be offered NIPT, and they have given NIPT as the first screening test. This is the first line test for all the mothers. Now yes, it has a detection rate, less false positive rate, and the detection rate is 99.8%. So now when I say that it has a detection rate, it has 99% detection rate, it is just for Down syndrome. It is not for all the syndrome, it is just for trisomy 21. For trisomy 13 and 18, the detection rate is decreased, that is up to 92 to 95% for trisomy 18 and 13. So whenever we are offering NIPT, so the detection rate 99% is not for all the trisomies or any other micro deletions and duplications, because nowadays there are multiple panels in NIPT which says that there are multiple. We cover all the chromosomes, we do micro deletions and duplications, but is there any paper which says that these also have a detection rate of 99%? No. For micro deletions and duplications, the rate is somewhere around 70%. Then if I talk about all the chromosomes, yes, for sex chromosomes X and Y, the detection rate is 95%, but rest others, other than the 3 trisomies, it is somewhere around 60 to 70%. And also it has certain limitations also, which we will discuss. So now, increased risk associated with increased maternal age, as we all know, the more the maternal age, the risk is automatically increased, but regardless of that, you can offer it to 23-year-old female who's expecting, you can do that. Now, why are we basically focusing on the trisomies, Down syndrome, Edward or Patau? So the reason is their incidental rate, the recurrence rate is very high. So as per Indian data, 1 in 700 babies are born with Down syndrome. Similarly, 1 in 6,000 and 1 in 8 to 15,000 of Patau syndrome. So now this is a classical picture of a karyotyping. So when you get a karyotyping, chromosome number 21. So if you see, all the chromosomes are in pair. But chromosome number 21 is one extra, so that is trisomy, which is basically a Down syndrome. So this will be a classical free trisomy picture for Down syndrome. If it is a Robertsonian, again it would be different. Now coming to the condition, yes, these are the clinical features, and also we are also screening for alpha fetoproteins. Now what if markers are at high risk? How do we know? So if we are ordering NIPT, if NIPT is normal, then yes, we can sit back and relax, and then we can rely on the on the ultrasound reports, and the routine NIPT positive hai, to MNIO या CVS positive hoga, let's terminate. It is a screening tool. Whenever NIPT comes out to be positive, it is mandatory to, at least from your side, you should write it on paper, on the prescription note, that this is just a screening tool. Further diagnostic testing is advisable. Now the advantages are that yes, number of invasive procedures decrease. If NIPT is negative, we do not have to rush for directly for the diagnostic testing. Also the false positive rate is very low, detection rate is high, and also because coming from because I have done a counseling, I have a degree for psychology. So this point reduces anxiety in pregnancy, plays a very important role. Down syndrome nahi hoga, but because of that anxiety, she may end up with X number of problems. So we do not want that. We want to reduce it more and more. So NIPT now, yes, the extended panels look at all the chromosome. Depending upon the detection rate, yes, it slightly gets lower. Then yes, if it is, so when should we offer? If it is a first pregnancy, second pregnancy, third pregnancy of a same female, or when? For all the pregnancies we can offer, because the risk for each pregnancy would be different. Now, what about twin pregnancies? NIPT in twin pregnancies. Can we do it or we should not do it? We can do it. Yes, we can do it, but the detection rate is 60 to 65% only. That too if it is a dizygotic. For monozygotic twin pregnancies, it is not advisable to go for NIPT. Reason being, we do not know which DNA is floating. But yes, if we have a dizygotic, we have two different DNAs, mother's DNA. So we get 3 types of DNA, and from that we evaluate. So we get number of peaks. So that is why it is said that we should not go for monozygotic, because first of all the detection rate is something, and if it comes out to be positive, how are we going to decipher which zygote it is? Then coming to the vanishing twin. So most of the time, when do we collect sample for NIPT for vanishing twin? After 7 to 10 days. Reason being, the vanished twins DNA is still floating in the mother's blood. We need to at least to kill the fetus DNA, the vanished twins DNA, and then we can go for NIPT. It also works in IVF cases if it is a ovum, if it is a donor ova or donor egg. It works, but again the detection rate is just 50%, because here also we have 3 DNAs. One for the ova, one of the mother itself and the baby. So the detection rate gradually decreases. So these are the recommendations which I just mentioned, which says that all the women should be offered for aneuploidy screening regardless of their maternal age, and it's not practical to choose a direct microarray or a large array for the screening test. It is better to go step by step, first screening and then diagnostics. So this is just a difference between what is the screening, the conventional screening, the dual marker, quadruple marker, and what is the NIPT. So as you all can see, if I talk about first trimester screening, just if I talk about with NTNB, quads, or if it is a serum integrated prenatal screening, so all of them, they have a detection rate somewhere between 80 to 90%. But when I talk about cell-free DNA, so yes, the detection rate is 99% for trisomy 21. Now coming back to what is the false predictive score for NIPT, it's approximately 4%, and 80% for all populations have, if it is high risk, it will be picked up, if it is low risk, it will be picked up in NIPT. Now coming back, now let's discuss about the diagnostic testing. So as we all know, if any of the markers, whether it is screening tools, the dual or quadruple marker or NIPT, if it is positive, or if it is multiple soft markers, if it comes out to be positive in the ultrasound, now what? Directly, most of the time it's like we have just recommended it to fetal medicine. But then again, whatever fetal medicine will say to the patient will ultimately come back to you. Ma'am, they have recommended this, what should I do? So here is the point why we should understand the importance of diagnostic testing. Yes, the procedure is done by them, but ultimate counseling, whether it is a positive report, negative report, and for the procedure itself, it is done by you all. So amnio and CVS, yes, it is done. Amniocentesis is done in 16 to 20 weeks. It is done up to 24 weeks also, but ideally it should be till 20 weeks, because that 1 month we should keep with ourselves for a buffer time, because we have whatever reports come out for the decision, we need to have that time. For CVS, it is ideally the best way to go for CVS, because here we have a lot of time. This is somewhere around 11 to 13 weeks where we should go for CVS. Now why do we need all these testings? Because this is things, and these 1.3 crore data that I am talking about here are those which could be detected at prenatally. So now the point is, when do we suspect that this patient could have a genetic disorder? So what is the correct time? Why? How? Because multiple times couple will come to you for preconception also, or most of the times they'll come with the conception ki it's already 6 weeks, it's already 8 weeks. When do we suspect that it could be a genetic cause? First, advanced maternal age. Yes, it plays a very, very important role. Second, recurrent pregnancy losses, which I am sure everybody here might be seeing it on regular basis. All the reports are normal, but still we are not able to find the root cause for it. Then infertility, either primary or sub-infertility. Then if there is a previous child with XYZ disorder, but whether it is he's suspected to have some sort of condition or it is confirmed, so then that is the time when we have to suspect. Because most of the time what happens, couple comes and says my baby is having autism, and now what? So as per the literature, autism only 15 to 20% of autism contributes in genetic disorders, but autism spectrum disorder, which is a part of n number of neurodevelopmental disorders, it contributes more than 80%. So if you read about neurodevelopmental disorders, most of them will be having ASD, that is autism spectrum disorder, which means the classical feature will look like autism, but whether that baby is actually having autism or not. So we need to have that understanding also to provide the preconception or provide further testing, because these tests won't be picked up by any of the markers. Then if the fetal is having multiple anomalies, definitely we can suspect, or if there is a history that previous pregnancy there was a multiple anomalies in the fetus, definitely in next pregnancy and next whatever pregnancies they are planning, we have to rule out, we have to check for that. Then if it's more than one soft markers, yes, abnormal aneuploidy screening, that is the screening protocol, and bad obstructive history. So now I'm sure you all might be aware of all the genetic tests that is present in the market. So we did a survey with doctors with armed forces in the defense pan India, where this survey was circulated amongst all the non-genetic clinicians. So the survey was basically, it was about how and what knowledge the clinicians have about genetic disorders. So 80% of them had fair theoretical knowledge. They knew what karyotyping is, they knew what exomes is, but only 2% of them had a knowledge that which test to opt for and when. So that we have recently published a paper also about this survey, which says that, and out of them 87% of people, clinicians said that we need to have more and more awareness programs to get more and more education about it, because Googles and textbook, nobody has the time to read word by word. So that is why they asked for it. So now when we talk about genetic tests, so genetic tests are basically classified into threes. One is cytogenetics, that is the conventional karyotyping, which you all are aware of. Then is a molecular cytogenetics, that is FISH, MLPA, chromosomal microarray, array, different names of different tests. Then is the molecular testing, where we actually go into a deeper of the DNA to check what exactly the sequence is, which is also known as next generation sequencing, NGS, Sanger sequencing, or exome sequencing, clinical, whole exome, whole genome, different jargons. So now I'll explain each and every test so that you will have a clear picture that, okay, here I can suspect this and here I can order this at least. So let's walk through a library. Imagine you have a map of a library which says that there is this library which has a round table in between, 3 shelves on the right side, 4 shelves on the left side, and this is a map, and it has a first floor, second floor, different pillars, everything. So you have an entire map into it. The moment you enter the library, imagine on the right hand side, imagine there is one shelf missing. Now what? That means you can easily suspect. Last time मैं आई थी, यहाँ पे 4 यहाँ थे, 3 यहाँ थे, कुछ missing है, right? Or if a round table is missing from the center. So this is what karyotyping does. Karyotyping, we have the above picture, it says that we have a chromosomes already mapped. Karyotyping, just look into it, it goes, check all are in place or not. If there is any missing or additional chromosome present in the karyotyping, it will pick up. So the trisomy, like for example trisomy 21, so here at position 21 there will be extra chromosome, which I have shown in last slide also. So this is what karyotyping does. Now the question arises, if there is a case of multiple pregnancy losses, so all the biochemical testing is done, male partner, female partner, everything is done, now what? Most of us writes karyotyping, couple karyotyping. What are we actually looking into it? Balanced translocations. But here when I say that this will only tell us the numbers, how is karyotyping going to work there? So this mapping works for the numerical karyotyping, when we are looking for the numerical change, whether it is trisomy, monosomy, polyploidy, aneuploidy. Now coming back to the balanced translocations. Now for example, I have 3 pens, black, blue and red. I have given it to you, it's all working. Now all the pens are working. Now जल्दी में what you did is black का cap red में डाल दिया, red का black में डाल दिया. Is it still working? Yes. It will still work because सिर्फ cap change हुआ. Similarly, the balanced translocations, the couple, those who are having balanced translocation, they will be asymptomatic throughout their life. उनको कोई problem नहीं होगा until or unless they try to conceive, because multiple balanced translocations are there, which actually tells that yes, it could be a cause of recurrent pregnancy losses, and that is what we are looking. So karyotyping 1 will look for the mapping of all the chromosomes, whether they are all present in same numbers, all are in pairs or not. Second, it will look for the balanced translocations. It will not look for unbalanced translocation, because अगर unbalanced translocation होगा वो चेक नहीं कर पाएगा कि वो पेन चल रहा है कि नहीं चल रहा. वो पेन चलाने के लिए we need to put off the lid and then we have to scratch the pen to check it on. So this is how karyotyping looks. Now you have already entered the library. Now you wanted to explore and read a book. So while you were walking and searching for your book, you just saw that there is one shelf which is disrupted, और आधे में books ही नहीं है. It's empty. What is that then? That is micro deletion and micro duplication. So that is what microarray looks into. So when we order microarray will look into micro deletions and duplications the moment you enter the library. That is, the moment you enter the chromosomes, it will start decoding the chromosomes as per its positions and locus. Now I have come to the library to read a book. Now I wanted to pull a book and I wanted to start reading it. Now when I read a book, I find out last time when I read a book, it says that fat cat ate the rat. But now when I'm reading it, there is a printing mistake which says fat mat ate the rat, which doesn't make any sense to me. This is what exome sequencing is. When it doesn't make any sense to a protein, which doesn't make any particular protein, amino acid नहीं बनेगा आगे, protein नहीं बनेगा, which causes a single gene defect, single gene disorders. So this is how we have to depict the genetic disorders in a form of a library. Mapping is done by karyotyping. Micro deletions and duplications of any chromosomal abnormality will be done by microarray, and exome sequencing or a single sequencing would be done by the exome sequencing clinical, depending upon that. So this is how we interpret. Now there are few case presentations. So this was a couple, a non-consanguineous couple, came to us, second gravida, healthy child, natural conception, came to us at 16 weeks of gestation, maternal age was 38 weeks. NT scan was done, NT and NB scan was done, and NB was absent and NT value was slightly increased. So the double marker was done initially at 12 weeks. So the risk was 1 in 94. So now, what would be the correct approach? Either MNEO, either NIPT. MNEO, right. But here what happened, as I've mentioned, that this couple came to me at 16 weeks, and dual marker would we have done somewhere around first trimester, that is 11 to 12 weeks के आसपास कहीं किया होगा. So the dual marker was done at 12 weeks 5 days. Routine NT scan was 3.5 mm. Dual marker test came out to be positive. Risk was 194, 1 in 194. Now the clinician waited for quadruple marker. 16 week में she did a quadruple marker. Quadruple marker also came out to be positive. Now what? She is already at 16 weeks. MNEO अभी भी उसको करना है. So अगर वो जो टाइम इस एक महीने का ऑलरेडी वी हैव spent so much, and all the trauma to the parent that happened, because this lady was having multiple abortions also initially. But then, so the correct approach would be, जब dual marker positive आ गया, NB absent है, NT already at high risk, dual marker but direct either go for it. MNEO.
The use of first trimester screening if you don't do CVS.
Sorry ma'am? Yeah, exactly. Definitely. But here they thought कि नहीं dual marker, because as I said, the detection rate is 90 to 95%. So there is a misconception कि नेगेटिव भी तो हो सकता है, बट वी डू नॉट जस्ट हैव टू रिलाई ऑन the cutoff that is given. We also have to rely on the soft markers, the biomarkers, NT 3.2 mm, absent nasal wound. So wo sab bhi we have to keep in mind. Then there is the second case. Non-consanguineous couple came to us at ongoing 10 weeks of pregnancy. This was a third gravida. So when the couple came to us, he mentioned that he has a male child, 2.5 years old, presented with developmental disabilities, multiple dysmorphic features, hypocalcemia, short stature, and underdeveloped chin. So the features looks to us pretty similar to certain disorder. Gravida 2, again missed abortion. This is the gravida 3, ongoing pregnancy, 10 weeks. Now couple wanted to know what is the risk. So they were well read and they said कि मैं हमारा MNO कर दो, because we wanted to be very sure. But now the point is, even if I order MNO, I'll do it. CVS कर दूंगी because she is already at 10 weeks. हो गया. But what I'm going to test for? So for that, at least I should have a diagnosis for the first child. That yes, if I know that if it is a chromosomal abnormality or it is a single gene disorder, depending upon that, I will provide that test in the further test. So here we directly, obviously we didn't, because the patient was, this proband 2.5 years old, was already roaming here and there undiagnosed. So we did the microarray directly straight away because it was fitting into Dijord syndrome, and the results also came out that yes, it is a Dijord syndrome. This is the most common deletion which is seen in the fetus and which can be ruled out. So when we did the microarray, it came out that first child was having Dijord syndrome. We offered amniocentesis for this couple because it took 20 days for microarray reports to come. So we took the we did the amniocentesis somewhere around 18 weeks. So before that, we were just doing the ultrasound. So during the ultrasound, we found out that this current fetus was again having congenital heart disease with different findings of facial dysmorphism was there, hypoplastic thymus was present, and also polyhydromas were there, which was a clear-cut indication. So we didn't wait for anything. We directly did the amniocentesis because just on the basis of ultrasound we cannot terminate it. We should have a proof. We did it, and it came out to be again Dijord syndrome with same deletion. Again, this is a similar case. 29-year-old female. There is no prenatal history, no significant family history. First trimester screening was negative. So here the couple sat back कि ठीक है हो गया. But when they came for the level 2 ultrasound, they found out that there was polyhydromas, suspected cleft lip, and VSD was present when fetal echo was done. So ideally तो फर्स्ट ट्राइमेस्टर स्क्रीनिंग हो गया था ना, अभी तो करवाने की ज़रूरत नहीं थी. बट देन दिस इज़ द इम्पॉर्टेंस दैट वॉज डन फॉर जस्ट फ्यू कंडीशंस. देर आर मैनी अदर which remain undiagnosed if we do not do the right test on right time. So again, for this we have sent the sample for QF, PCR and microarray, and then we got to know that this was a Dijord syndrome and there was a large deletion of 2.5 MB. Now this was a classical case where the couple, 34 years old female, second gravida, presented with the ultrasound suggestive of erythrogyposis. So she also said that my previous pregnancy also, it has similar ultrasound findings, but no genetic workup was done and no reports were there with the couple. So we clearly thought, we did the ultrasound again. So the classical features of this erythrogyposis is that it has longer limbs and a closed fist. So the fetus never opens the fist in this condition, and it is because of a single gene. There is a single gene disorder which is a autosomal recessive condition. So we did the whole exome sequencing for this couple, for the fetus again. Through amniocentesis, we took the sample, amniotic fluid, and the sample was sent to the lab, and whole exome sequencing was done, and we got to know that there was a homozygous variation for this. So now the question is, if the same workup was done previously, so they wouldn't have to go through all this. So this is the importance why we should do for it. Secondly, the couple clearly mentioned that we are consanguinely married. When there is a consanguinity, the chances of homozygous disorder also increases. So all these small details we have to keep in mind while giving the certain answers. And after that, we did the parental segregation also. We checked for the same duplication in the parent, and we got to know both the couples were the carrier. So here we terminated, but then for the next pregnancy we offered, and CVS karvaya, there was no risk. So we have given this patient 3 options. One was either you can go for normal conception, but there would be 25% chance of having affected child, 25% will be normal, and 50% will be carrier just like you. And you have to keep in mind that a carrier doesn't get married to carrier. That was through normal conception. Second was through IVF karvao, but in that case the condition was that you have to either have a donor egg or a donor sperm. Third was PGT, where they have their own sperm, own egg, and then they do the testing further, and whatever embryos will be fine and without this mutation will be inserted. So this is just a question because this is the most commonest condition that comes, and you might might have been witnessed it. So a couple came for preconception counseling, and they said that their first child is having thalassemia and is getting frequent blood transfusions. So how are we going to go about? But there is no genetic testing done as of now. Nothing is done. Only the biochemical. Yes, here we will first go for HBB. HBB is a gene which is responsible for thalassemia. We will go for HBB gene sequencing for the first child, not for the couple here. Now, interestingly, this child was somewhere around 3.5 years old. We found out he was not thalassemia major, he was sickle cell. And every third day this child was getting blood transfusion. And because none of them opted for genetic testing, कि कौन उन चक्रों में पड़ेगा, बहुत expensive होता है, ये होता है, वो होता है, and then when we did the testing on the, obviously we have to go for the baby first. We got to know, we saw it that it is a sickle cell disease, and they have clearly mentioned that, ma'am, we belong from a Sindhi family. So Sindhis have this variant very, very common. Punjabis and Gujaratis have HBBD variant, which is another variant, but Sindhis have this. So all these things. So the day we did this testing, we put him on the treatment for thalassemia. Now once in 6 months he is getting blood transfusion. Now for the second pregnancy. Firstly, yes, for parents, we knew that yes, parents would be carriers, but then still, as per the textbook, it should be mentioned on the papers that yes, we have offered prenatal segregation. We offer prenatal segregation, parents came out to be carriers, and for the next pregnancy, we said that it's 25% chance. You can directly go for the normal conception if you want to. Otherwise, because it was just second gravida.
What do you mean by parental segregation?
So parental segregation में मैम होता है कि we take the blood sample from the parents and we just check this particular mutation HBB C.20A2T. We will just check that variant in parents. So यहाँ पे it is written homozygous कि जो दोनों copies होंगी gene की will be affected, but in parents just one copy of the variant will be affected, one copy of the gene will be affected. But for the affected ones, both the copy will be, because it is an autosomal recessive condition.
It is done on both the parents?
Both the parents, yeah.
And we will like to know whether the mother is homozygous or the father?
No. Mother and father won't be a homozygous. They will be carrier only. अगर वो homozygous होते, तो since birth उनको भी blood transfusions होता. So most of the time, people say that अच्छी भली pregnancy चल रही थी, suddenly there is a blood drop in the mother. ब्लड हीमोग्लोबिन कम हो रहा है, पता नहीं क्यों हो रहा है, अच्छा ब्लड चढ़ा दिया, बट HPLC कर लिया, बट देन was the HBB sequencing done? Because HPLC is again a screening tool. Even if the values are high in HPLC, it will just tell you the markers, the peaks right? It will not tell you the conclusive results of it. You have to interpret as per the ranges, but then the ranges are increasing and depicting every single day. So in genetics it is said every new variant is discovered every single day, every new gene is discovered every month. So this is what is the importance, that why we should opt for right test and when we should opt for. So ये पहले करा होता तो शायद वो 2.5-3 साल तक उस बच्चे को प्रॉब्लम नहीं होती.
But actually, the pediatrician do not diagnose the thalassemia major.
they HPLC सिकल नहीं किया मैम, HPLC किया बस. तो पूरा HPLC नहीं किया ना, उनको ब्लड ट्रांसफ्यूजन हो ही रहा था because he had a proper hemolytic phase. Yes, yes, he had a typical hemolytic phase. Hemolytic phase में ये होता है कि जब muscles get weakened and it start drooping down. So वो उनको लगा कि वो तो classic case है. But when we did a genetic testing, there is when we got to know the difference. And up it is fine. And similarly for next pregnancy.
How common it is to have thalassemia as well as sickle together?
It is because there are multiple studies, multiple patients where we found out that the baby is having one, because it is the autosomal thalassemia trait का कोई भी HBB gene sequencing में HBB का कुछ भी होगा, it will be in autosomal recessive form. Now either it is homozygous or it is compound heterozygous. So compound heterozygous का मतलब ये होता है that one gene is having this mutation, the other one is having thalassemia major mutation. So अगर mother is a carrier of thalassemia major, that is the most common is IVS 125, वो वाला variant, and father is a carrier of this. So बच्चे को तो compound het हो गया ना, mother से भी उसको affected मिल गया, यहाँ से भी. So it become thal sickle disease. Yeah, it is rare, but we have, because so nowadays it should be a practice. HPLC everybody is doing, but then yes, we should get at least for mother at least HBB gene sequencing done. It is not expensive. It is hardly what, 1,000 rupees or something.
कहाँ कराते हैं?
Ma'am, it can be done in any lab. Even Pathkind does it. It is just a HBB gene sequencing, and you will get a report within a week. So ma'am, for all the pregnant, yes, all the carriers का पता लग जाएगा. So for example, if all minors and carriers, so if in case, for example, if there is a couple, आपने अपना उसको prescribe कर दिया, it comes out to be that you know that she is a carrier, then you can ask her partner to get it done. If partner is also a carrier, then we have to do a diagnostic testing on the fetus. So this is how it will work.
What about HbF?
HbF is again a ferritin levels, because then we need to check the ferritin levels, how high the ferritin levels are.
These days some reports are saying fetal hemoglobin.
Yes, so that is again the HbF is the ferritin levels, where we need to check the ferritin levels, and depending upon that again we need to go back for the gene sequencing कि अगर वो high आ रही है तो it is because of what mutation that is causing it.
What is the prevalence of this compound?
Ma'am, it is not the prevalence basically, it is just the thalassemia is very common disorder.
Thalassemia is common, but sickle along with the...
It is there. It's less, but then it is there in India. It is there. Because, yes, so if Punjabis and Gujaratis are getting married, right? So like for example, I'll tell you my case. I am a Punjabi. My fiance, he is a Gujarati. So the day I got to know that we are going to get married, फटाफट से blood sample दो 4 ml, I need to get it tested done. That's it. My mom was like, नहीं मुझे horoscope मिलवाना. मैंने कहा नहीं मुझे blood मेरे को DNA दे दो. I am more than happy. So this is how the not even me, I am in genetics, chalo I know, but the couples nowadays, they are coming with it कि ma'am, we have read about it. So now for example, आप लोगों ने केस देखा होगा about SMA, spinal muscular atrophy, very common, जिसमें there is a crowdfunding going on. Amitabh Bachchan is telling, Farah Khan, all the big shots are telling to have a crowdfunding. That is just a simple carrier test. Parents का हुआ होता तो बच्चे में नहीं होता. So there are certain tests that should be done, and it is
हमारे पेरेंट्स का नहीं करवाते, बच्चे का पता चलता है, और वो लेडी हमसे पूछती है कि डॉक्टर साहब आपने ये SMA क्यों नहीं कराया? यस, डॉक्टर साहब आपने क्यों नहीं कराया? because the treatment is so expensive. Crores में treatment है बच्चे का.
16 crores. 11 crore is the medicine, and because it comes from US, and it comes from US, and the 5 crores is the costing with all the GST and everything. 16 crores for the SMA. So we are giving at armed forces, yes, we are giving treatment to the patients, but then bahar it is not possible, and that 16 crores is not throughout life. 1 year 16 crore, second year again 16 crore. So it is like unbearable. Mother and father would be carriers. Mother and father would be carriers.